Look at us right now. Yeah, okay. So today we're talking about the pediatric gastro system. Tomorrow we'll still kind of carry over, and in the second half of class we'll talk kind of about both, because we're going to play Jeopardy. So PKU, of course, when we did our maternity at the beginning, we talked a little bit about PKU, those 24-hour tests that we do on the newborn. Some of you have got to see the nurses do that. Some of you may have got to help a little bit. So that PKU is something that we have to assess for after 24 hours. Okay, it cannot be assessed for before that. Okay, they have to have had 24 hours of protein in their system. Okay, so feeding, breast milk, or formula, either one. Okay, so the body cannot absorb the phenylalanine, and this enzyme, which is tyrosine, is what they're missing. Okay, so tyrosine and phenylalanine. So if you think about physiology, when you took it before you came into nursing, how each enzyme affects each other, how they kind of go together. And so the body doesn't produce that tyrosine, and so any phenylalanine, it just continues to build up and build up and build up and build up in the system. And this amino acid is produced whenever they take in protein. Okay, and so these kiddos can have abnormal brain and CNS development. Pigment is affected, and usually they can have mental retardation or difficulties at learning if it's not caught early. If it's caught early with that PKU test, then they can change their diet, and then it reduces those risks and effects. So signs and symptoms, you're going to see failure to thrive, frequent vomiting. They're going to be hyperactive and have erratic behavior. So we use that Guthrie test, which is the 5-spot blood test to diagnose this. And they're going to do it at 24 hours, and some states do require them to repeat it at 2 weeks. It tests for that excessive phenylalanine in the bloodstream, and they have to be 24 hours before you can assess it. Diet is how it's controlled. Okay, there's not anything else they can do except diet. You want to do a low protein, low dairy diet on these kids, because again, protein is what causes that phenylalanine to be produced, and they do not have the tyrosine to break it down. And so the biggest thing is education of diet to the parent. You're going to have to do a lot of education, because if the parents aren't understanding the diet as, it's easier when they're small and on formula, so you can say, this is the formula you buy. But then whenever they get older, then they have to be educated more about what has protein, what doesn't have protein, and make sure they follow those diets. Okay, so we're going to talk about failure to thrive, or you're going to see it as FTT sometimes. This is actually a syndrome. It's not a true diagnosis. So you're not going to have, like, if you've ever heard of CPT code, someone's admitted to the hospital, they have to have a primary diagnosis, and then failure to thrive can be like the due to. Okay, so dehydration due to failure to thrive. Failure to thrive cannot be your primary diagnosis, okay, because it's not a diagnosis, it's a syndrome. So it's an infant or young child. Children fail to eat enough food to meet requirements for nutrition of energy. So you're going to think about what are the different things that could affect that. The signs and symptoms, they're going to have growth delay, less than the 5th percentile on those growth charts. They're going to have developmental delays. So who is at risk? Kiddos that are in poverty, parents that maybe don't have enough money, are unaware of the programs like WIC and things like that to be able to help them provide food for their kids. Maybe this was an unwanted pregnancy, unwanted child, and the mom just does not bond with them. And then, therefore, you hear those horrible stories where they lock the kid in the closet and the 8-year-old weighs 20 pounds and looks like he's about a 1-year-old, horrible, but it happens. Family stress, or maybe the child is preterm, okay, and they just have that difficulty, dyspeptic swallow, and they're having issues being able to gain weight. So diagnosis, you're going to roll out physical cause. Again, with preemies, It could also be due to a gastrointestinal issue that's causing the failure to thrive. Or is there physiological or psychosocial issues that could be causing this problem? So again, just remember, it's not a diagnosis, it's a syndrome, okay? And this is just where these kids do not get enough nutrition to be able to survive and grow. Poison ingestion. This is the most common at age 2. Common poisons you're going to see is medications, cosmetics, foreign bodies. I kind of told you on the lecture I had a cousin, his name's Trey. When he was little, he had a bottle of Dimetapp that my aunt had sitting around. He went to his sister's room and drank and spilled some, but she didn't know how much he took in, so of course she has to call poison control. They just watched him. He didn't have to go to the ER or anything. Well, this is the same kid that not long after started playing with a lighter in his sister's room, same room, caught the pom-poms on fire and the whole house had to be evacuated, and it basically was destroyed. This is the same kid that unlocked the deadbolt and the little chain thing and disappeared for a whole Saturday. Nobody could find him. They had police out. They had roadblocks, not letting anybody leave. And when they found him, they had a pontoon boat, and he was asleep underneath one of the seats. Yeah. He's a good kid, though. He's an adult now, has 3 of his own, and I'm sure he's paying for his raisin. So when poison ingestion occurs, this can be an emergency, especially related to adult medications. You have those little Monday, Tuesday, Wednesday, Thursday little packages that a lot of older people will put their medication in. Well, what can happen? Grandkids visiting grandma, it's sitting on the side table because that's where grandma takes her medicine. The kid knocks it down, picks it up, opens it up, and takes in medicine, okay? A lot of adult medications, the strengths of them can really affect that kid. So the most important thing is you're going to try to identify what they could have taken, and then you're going to call poison control. I've even as a nurse had to call poison control from the ER because we don't always have the protocol of what we're going to do for certain medications. And so that's why you call poison control, because then they have a pharmacist that's on there that you talk to, let them know what they think they've ingested, and then they let you know what you need to do. You need to induce vomiting because some medications you can't induce vomiting, or you shouldn't. Then we use charcoal, activated charcoal. So poison control, even in the hospital setting, is usually what we use in contact because we don't have, for every possible thing a child could ingest, we don't know what we're supposed to do. And they possibly are going to have to go to the ER, okay? They could need activated charcoal. If eye is involved, then you're going to start flushing at home 15 to 20 minutes with water, okay? And most hospitals have those little sprayers you see, they test them every day to make sure they work. At home, you may not have that, so utilize whatever you have. If you have to have the kids lay their head over the sink and you just keep pouring water in their eyes until you can get them to the hospital, do that. Foreign body. So this is most common from 6-month-olds to 3-year-olds. This is when those kids kind of start getting mobile. You put them in the floor, they're crawling. Brothers, sisters drop a Lego or a penny or a quarter. Or maybe mom and dad, gives older brother or sister grapes, and little one is given a grape by the big brother. Grapes, hot dogs not cut up, and balloons are some of the most common things children can get stuck in their esophagus or trachea and cause problems, okay? So you just have to be careful when you have a little one around, making sure that everything's picked up because they're going to put everything in their mouth. It's just natural. That's what happens. Diagnosis usually is going to be an x-ray. It could lodge in the narrowed areas, or it could go on through and pass in the stools. They may need surgical removal. So think about, those little magnets are kind of in right now where people build things with a little ball magnet. Well, if you get 2 of those inside a kid's digestive system, and one's a little farther up than the other, but then they connect, are they going to be able to move? No, those will have to be surgically removed because what's going to happen is you could cause an obstruction, you can cause interception, or where it burrows through and then they have an opening. Those little batteries and like watches and some toys, those are very dangerous because they ingest them doesn't pass, that battery acid starts to erode into the intestines, and then you have an issue. Okay, so it's just always important to just kind of keep your floor clean, even if it's a niece or nephew. That's one thing you should think of. What do I have down and around that they could possibly get and put in their mouth and cause a problem? Cleft lip and palate. So this is when you have a failure of fusion of the primary palate at 7 to 8 weeks gestation. Okay, so this is while they're still inside mom's womb. It can be unilateral, which is just one side, or bilateral, which is both sides. This can lead to failure to thrive. They usually have a special feeding nipple. It's really long and it's big around. The tip is smaller, and the reason you have such a long one is you actually want it to go more to the back of the throat than to the front, because you want it to pretty much go down, because you don't want aspiration and you don't want it to get up into those nasal passages and cause irritation. You want to prevent aspiration, so these kids are pretty much going to be set up every time they eat. Okay, you do not want them laying down. The only treatment is surgical repair, and this is usually multiple surgeries. Like, they can't repair it in one surgery. And sometimes they're going to have the palate fixed at baby age, and then they're going to have reconstruction again as they grow and get older, because that part that they fixed is not going to grow with it. Okay, it has to be redone again. So what are we going to avoid? We cannot put them in a prone position post-op, because we do not want that going forward, anything going forward and into those suture area that could cause infection, like vomit or anything like that. You want to try to prevent crying, because you want to protect those sutures. Think about when a child's stressed, what's the first thing that does? Their mouth comes wide open and they're screaming. That could cause stress on that suture line, so you want to prevent crying. The other thing is education to mom and dad. These parents could definitely have problems bonding with baby, because, you know, a lot of times cleft lip and palate is not caught on the ultrasound. Baby's born and, oh my gosh, we have cleft lip, cleft palate. And, you know, parents are expecting normal, happy, healthy baby, and then all of a sudden their baby doesn't look how they expected. Okay, so education on the part and support is very important for these parents. So we're going to talk about esophageal atresia. So this is a non-continuous tooth. So that esophagus has formed, but it doesn't keep going down to the stomach. Okay. Tracheoesophageal fistula. This is an abnormal connection between the trachea and esophagus. So basically, you know, your trachea and esophagus start, but then they form one tooth. Okay, going down to the lung and the stomach. So these kids are at high risk for aspiration pneumonia. So what is one of the things we're going to see? We're going to see a maternal history of polyhydramnios in pregnancy. Why would we have hydramnios or polyhydramnios? It's the same term. Fluid builds up. And why does it build up? Right. If you have the esophageal atresia, that baby, they are supposed to practice swallowing. Part of their amniotic fluid is the pee they void out. Okay. But what happens is they can't swallow and have that fluid go through their body and then pee it back out. So what happens is that fluid just builds up, builds up, builds up, builds up, because there's just an excessive amount of fluid. Okay. So this develops between 4 to 5 weeks gestation. So some signs and symptoms you're going to see is drooling, coughing, sneezing, which sneezing is hard because a lot of newborns sneeze because they can't sniff. So they naturally sneeze to kind of clear those nasal passages. They're going to have respiratory issues. These kids are going to be cyanotic at birth, maybe not even start breathing, or they stop breathing after a few minutes. They have feeding problems, and you're unable to pass the NG-OG tube. So that's also one way they diagnose. If they try to put an oral gastric tube down the throat, to just decompress the stomach or whatever, it's going to coil up, and they're going to look with an X-ray, and it's going to be coiled. Not always. Yes. Yep. This is one of those things that, you know, baby may cry initially and do great. And if they have that tracheoesophageal fistula, they're not going to be able to take in as much oxygen into their lungs. So then you're going to see that initial cry, and they're going to be blue anyways, because most babies are blue when they're first born, but they're never going to pink up appropriately. And you're going to think, okay, there's something going on. So then you're going to take them to the nursery, put on oxygen, and then they're going to have to start assessing what's going on. Okay. The other diagnosis is going to be monitoring bowel and gas patterns, and then they're going to do like a contrast evaluation, okay? But it's going to be evident something's not right. If they have the esophageal atresia, you feed the baby a bottle and immediately it comes all back up, okay? Feed the baby a bottle, it all comes back up. And then you don't have any passing of the stool, maybe hypoactive bowel sounds. So there's a combination of things you're going to have to assess to then diagnose, okay? Gastroschisis, this is a congenital defect in the abdominal wall that allows evisceration of the abdominal contents and may include intestines and other organs. It usually occurs to the right of the umbilical cord and the rectal muscle. So this is when the intestines are outside. There's not a sac around it. It's just outside of the body, okay? There's a 10 to 15% mortality rate on these kids. It can be due to maternal age, smoking, alcohol use, teratogenics like aspirin. But sometimes it happens and we really don't have a reason. Okay, one of my best friends in high school, her first daughter had gastroschisis without, there was nothing. And they didn't know it until she had her growth scan, and then they could see that the intestines were not inside the tummy, they were outside. So she actually went to Dallas and had her via C-section, and she was in the NICU for a while. So what are we going to do for these kids? What are some complications you can think of immediately with that? Intestines being outside of the body. Infection. Loss of what? Loss of heat. Heat, right? Because they have more body surface area.
Respiratory.
Ischemia, necrosis of the bowel if it's not treated quickly. Obstruction, respiratory issues. Okay. So there's a lot of things you're going to have to consider and they're going to have to prepare for when this baby's born. And usually, this is going to be taken care of quickly. On the next slide, you'll see they're going to put the baby in a plastic sack up to its armpits, and they're usually going to cover it with a moist dressing, or they're going to fill that bag with saline because you want to keep warm saline because you want to keep their body temperature warm, but you also don't want that intestine to dry out. Okay. So omphalocele is similar to gastroschisis, but it's actually in the sac. Okay. When a baby's intestines are formed, they're kind of formed inside that umbilical cord, and then they slowly move back down into the abdomen, and then it's sealed off. So with omphalocele, what happens at that 10th week of gestation, that those intestines fail to go back into the abdominal cavity, okay? And it is encased in the translucent sac, so that's how you know the difference. Gastroschisis, they're just out in the open air. Omphalocele, they're in a sac, okay? And usually it's kind of connected to the umbilical cord. 30 to 35% mortality rate. This one now has some other anomalies you're going to see. So these kids are also going to have to be assessed for cardiac, neuroskeletal, and genitourinary, okay, because they could have other issues related to that. These are also common with trisomy 18, 13, and 21, and advanced maternal age. So risk and interventions for both. So risk, massive heat loss, increased caloric requirements, intestinal obstructions, infarctions, infections, septicemia. Y'all got them all. That'll be good. Interventions, you're going to place that baby in a plastic bag up to the axilla and fill it with warm saline. They're probably going to have an NG tube placed. You're going to measure the abdominal girth, assess bowel sounds, and monitor for signs and symptoms of infection. Okay, these kids are usually going to have surgery pretty quick, within 24 to 48 hours after delivery. Oh. What? Okay. Slides decided to go crazy. So Hirschsprung's disease, this is an obstruction from decreased motility in part of the intestines. It's absence of the autonomic parasympathetic ganglion cells in a segment of the colon. So this may involve the anal sphincter only, or it can involve just part of the colon, or it can involve the whole colon, okay? In newborn, you're going to see a delayed passage of meconium. You can have bile state vomitus or odor of the feces. In a child, you're going to see ribbon-like foul-smelling stools. You're going to have decreased feeding and potential failure to thrive. Can y'all tell us typing these about 11 o'clock last night? I've missed a few letters here now. Abdominal distension is progressing to respiratory distress and shock. Diagnosis, you're going to do a history, so you're going to have to ask parents because, kiddos may have no issue at the beginning, or you kind of have maybe some constipation, but they chalk it up to constipation. They're on formula or whatever. So you're going to have to take a detailed history of the parents. Ask what their bowel movements are like. How often are they having them? What do they look like? What do they smell like? You've got to get detailed. What's the color? X-ray or a rectal biopsy. Treatment is enemas, surgery, and they may have to have a colostomy to allow that part of, because they're going to remove that part of the colon that doesn't have those ganglion cells. So they'll have a colostomy until it heals, and then they'll be able to reconnect that bowel to the anal sphincter. Unfortunately, sometimes these kiddos do not. If it's a whole colon involved, they may have to have a colostomy or ileostomy forever. I actually do know a little girl that she's 13 and has Hirschsprung's, and they were hopeful that with newer treatments and medication that she would be able to have reconnection. And this last year they found out she would have to have a colostomy for the rest of her life. So it was very heartbreaking for her. Gastroesophageal reflux. So this is a transfer of the gastric contents into the esophagus, and that lower esophageal sphincter is relaxed. So this occurs in everyone. Everyone in here has probably at some time had reflux, right? I hate it. It happens to me sometimes in the middle of the night. If I eat too late, I wake up, I feel like I'm coughing my head off because I am, because everything's come up. But what makes it irregular is the frequency and the persistency. That's what makes it abnormal, okay? If you have it more often, recurring throughout the day, every day, then that is when it's considered abnormal, okay? Everyone's going to suffer from a reflux at some point due to spicy food, or you ate too late, or you drank a little too much and ate too late, or, sometimes that happens. So they also can be related to hiatal hernias, and that's just a herniation close to that esophageal sphincter, okay? And it causes that to not completely close, and then you have that reflux. Signs and symptoms can be excessive and non-forceful vomiting in a baby. That's what you're going to see. Okay, these kids are the parents are going to say, oh my gosh, they spit up all the time, because it's not projectile. It's just a little bit, all the time, constantly. They burped them good. Their abdomen's not distended from being gaseous, but they're still constantly spitting up, okay? It usually starts in the first 2 weeks of life. You can diagnose with a barium esophagram, a scan with dye, or the Tuttle test, which is the pH. You check for that pH in the lower esophagus, and they're going to do sometimes pH tests on the spit up, okay? You're also going to look, what is that baby spitting up? It can be milk, sometimes it's curdled milk, and then you're also sometimes just going to see a mixture of that and acid. So treatment, we're going to do frequent burping, try not to overfeed, positioning, and that's usually what they start with. They want you to kind of see if you can maybe reduce the symptoms by doing that before they start giving the baby medication. Pharmacological interventions. So if you have a person who has severe reflux, they're going to have this fundoplication, okay? So this is where they actually take the esophagus, okay, which is usually attached to your stomach, okay? But what they do is they actually take this part of the stomach and they pull it up like this, okay? So they kind of stick that esophagus further down into that stomach. So then when acid comes up, instead of going straight up into the esophagus, because it has a straight line here like it would, it's going to go up and around, okay? So that's how that surgery works. The only thing that's bad about the surgery is these people have a hard time burping and vomiting afterwards, okay? So they actually have discomfort if they feel like they need to burp or vomit. But you have to look at risk to benefit, okay? Is it more beneficial to not have erosion of that esophagus, which could lead to what? Ulcers? What else?
Burning of the esophagus,
You could have that where you have that irritation throughout, but also that can lead to what? Poor nutrition, infection. It can. It can lead to esophageal cancer. Okay, that irritation of that esophagus can. Okay, so reflux is common, but it can be abnormal. Pyloric stenosis. This is the constriction of the pyloric sphincter with obstruction of the gastric outlet. The muscle of the pylorus may enlarge to twice the normal size. It's going to kind of, when you do an x-ray, it's going to look like two olives sitting on top of each other. Signs and symptoms are going to develop within the first weeks of life, regurgitation and vomiting, and this is going to be projectile vomiting. We talked about reflux, it's just going to be kind of spit up. With pyloric stenosis, they are going to have projectile vomiting, okay, because it cannot pass through that caloric sphincter into the small intestine. It's going to contain gastric acid and undigested milk. These kids are going to have failure to thrive, dehydration, metabolic acidosis. You can actually see the visible peristaltic waves in the abdomen of the lower intestine because it's trying to help move that food down, but it can't. Palpation, you're going to feel those olive-sized mass, and they're going to have decreased stools because none of the milk or food's going into the small intestine and colon to be absorbed, and so it's not making the stool. So how are we going to diagnose? We're going to take a history from mom or dad, palpation of the mass, and an upper GI x-ray. Treatment is going to have to be surgery. You can't, the only way you can fix that, that sphincter is to go in and operate. And it's usually going after that first 4 to 6 hours. You're going to start giving them small amounts of fluids and see how they react. They can have vomiting for 24 to 48 hours post-operation, but it usually resolves. You're going to elevate the head of the bed and decrease the oral intake until it's tolerated. So small amounts until they can tolerate a little more, a little more. So kind of like the diet has progressed, you're going to progress the fluids as they can tolerate more until you can do thicker fluids to soft foods on. Okay. Intussusception. So this is the most common cause of an intestinal obstruction in children. So it's a telescoping or invagination of one portion of the intestine into another. So you have the intestine, okay, small intestine, and what happens is it literally sucks itself back up into it. Okay, it's used to be called telescoping. It's one easy way we called it, but it's intussusception is the diagnosis. So you've got your tube going down, and for whatever reason, it pulls itself back up into itself, and that's going to cause a blockage. Okay. So you're going to see current, and it's most common in that ileocecal valve. Okay, and that's the valve between the small intestine and the colon. Okay, that ileocecal valve. So you're going to see current jelly-like stools. You're going to have abdominal pain. You're going to possibly feel an abdominal mass where that intussusception is. They're going to have bloody stools. On diagnosis, they're going to do an ultrasound, and it's going to be a bullseye-type mass. Okay, that meaning you can actually kind of see that being pulled up in there. Treatment, usually they're going to start with conservative. So they're going to do an air or saline enema. So what that's going to do as you're pooping, hopefully it's going to help that bowel kind of start moving back down and out, okay? The non-surgical treatment is about 65 to 75% effective, so it works, okay? So they're going to try that first before they go in and do surgery. But if those are unsuccessful, surgery is indicated, okay? They're going to go in and have to probably remove that portion of the bowel and then reattach. Malrotation and bolus. Okay, so malrotation is due to abnormal rotation around the superior mesenteric artery during the embryonic development. Bolus, it occurs when the intestine is twisted around itself and compromises blood supply to the intestine. So that can occur at any time. Your malrotation usually is in the development of the embryo. It can cause perforation, peritonitis, necrosis, and death. So on these, they have to have rapid surgical intervention, okay? You don't want that intestine to die. Once it's noted and seen, you're going to have to fix it quickly because you don't want necrosis to start. Hernias.
been doing that when Taylor was here too.
I think it may need a new battery. Hernias. So most people know what hernias are. You may have had one yourself as a kid or even now as an adult. So it's a protrusion or projection of an organ or part of an organ through the muscle wall. So the muscle wall has an opening. Maybe it's torn, maybe it didn't form together correctly, so you have an opening. So then what's going to happen is part of your intestine's going to come out. Is this bad? Yes, it could be, because what happens is if it gets too much out and it gets inflamed, it's not going to go back in on its own. A lot of times in babies, especially inguinal hernias, you're going to see it when they're changing their diaper and they're going to be really ticked off at you, and then you're going to see those bulges come up in that inguinal groin area. And then once they stop crying, it usually goes back in, okay? So these usually have to be fixed because you don't want that bowel to get caught in that hernia. So you can have inguinal, umbilical, congenital diaphragmatic hernia. So our congenital diaphragmatic hernia, this is life-threatening, okay, because it's going to be potential for RDS, because what happens is that diaphragm has a hole in it, and as that baby was formed and growing inside mom, all the intestines were able to move up into that part of the cavity, and those lungs have been compromised, okay? So they're not going to be able to breathe like they should when they're born because they have less space for those lungs to expand, and so you're going to have respiratory distress syndrome. These kids are not going to be able to breathe well. You're going to have barrel chested because they have excess organs up in there, so they're going to have a barrel chest, and a sunken abdomen because everything's where it's not supposed to be. And the only treatment for this is surgical repair, and it's usually done quickly because you've got to get those bowels out of that lung cavity so they're able to breathe appropriately. Constipation. So you guys are going to cover constipation. I'm sure y'all heard it in Chanessa's lecture. So it is, again, a symptom rather than a disease. So you cannot admit a patient due to constipation. You're going to have to say dehydration or whatever else is going on with them, and then use constipation as secondary. And it can be related to other disorders, and it's a secondary thing that happens after. Chronic constipation may be due to environmental or psychosocial factors. Idiopathic means you have no known cause. So in infancy, it's often due to the diet. So certain types of formula, you will pretty much, I could say 100% of the time, will never see a breastfed baby with constipation unless there's a gastrointestinal issue like a deception or something like that. Because breastfed babies, they do not get the same kind of proteins that they have to break down, and so their stools are usually looser, thinner than a baby that's on formula. So in childhood, it's often due to the environmental changes or control over body. So maybe they, some people do not like to go to the bathroom in public, and this is really hard sometimes for kids because they don't want to be embarrassed being in the bathroom at school and being the one that makes it stinky. So they're going to hold it until they get home. Well, then when they get home, they don't have to go, and then the next day, they feel like they got to go and they're going to hold it again. So control. It may result from stress, okay? So our nursing interventions, we're going to take a history. We're going to educate the parents, maybe make dietary modifications like high fiber diet, make sure they're getting enough fluids. And you're going to avoid laxatives in kids, okay? We do not want them to lose the good stuff by pooping all the time, okay? They need that absorption of that food in their body to grow, and so if they're constantly giving laxatives, it's going to cause that food to move through their bowels too quickly, and they're not going to have good absorption. Okay, but fiber is okay. Like the one that they will give kids is Miralax because it doesn't work like other laxatives. Okay, it's not as hard on the system as other laxatives, so you will see Miralax, but usually they're going to try high fiber diet, increased fluids before they do Miralax. Miralax is kind of the last intervention if they're not able to go with the other interventions. Acute appendicitis. So signs and symptoms. Can somebody tell me where the McBurney point is and how are we assessing that?
On the right side, isn't it?
On the right side, where? High, upper, lower? Lower, okay?
It's like appendicitis, isn't it?
Right, this is how we assess if it's an appendicitis. So what are we doing at that McBurney point? Okay, you're palpating. So how am I going to palpate it though? Okay.
Because you're gonna press on the other side and do like a quick release, right?
Right. So usually right or left. Sometimes it will happen on the left, but it's most common on the right. So you're going to push down and then you're going to release quickly. So with the push down, they're not going to have discomfort. It's going to be the release quickly and they're going to have pain. Okay. When you release, then it's going to be very painful. There's also one that it has a funny name, but we don't use it. Is where you have them position their leg a certain way and bend their knee up, and they'll have discomfort and pain with that. Okay. Most common, you're going to just see the McBurney's point where they're pushing and let up, and if they're, hurting in that area, then they're going to say we need a scan. Some of these kids are going to present with fever, nausea, and vomiting. If they have pain for several days with sudden resolution, this could be a rupture. Okay, so if they're saying, oh my gosh, I hurt, they're in the ER, I hurt, and then all of a sudden they're like, oh, pain's gone, but they still look sick, that could be a potential rupture of the appendix. Because the appendix is no longer inflamed and being, pushed on by the inflammation and infection, it's burst, so that pain's going to disappear. So that's when you know, oh goodness, something may be severe wrong, because what's going to happen if it has ruptured? Infection. You're going to get peritonitis. Okay, you're going to get septicemia. So the treatment is usually going to be a laparoscopic procedure. Now, since we've done some studies, if we catch it early enough, some kids can just be given IV antibiotics in the hospital, and it can reduce the size of the infection in the appendix, and then they're not going to do surgical removal. Okay. Used to, anybody who came in with symptoms, you automatically took that appendix out. Used to, when women had hysterectomies, even though their appendix maybe looked fine, they would just take it out because they're like, oh, potentially one day they could have an appendicitis, so let's just get it out there. So, yes, sir.
That McBurney point thing, is it only applicable to the appendicitis, or could you use it for, like, say, like a palpating like a lymphoma or something, even though it wouldn't be painful?
It's mainly just appendicitis. That is the one that we use definitively most of the time prior to when we had good x-rays and CTs and things like that. That's the oldest way we would be able to assess. And it's just because of that rebound. Lymphoma, you're going to have discomfort, but it's not going to be the same pain because it's not going to be that, aggravated, infected organ, basically. So if ruptures occurred, they're going to have an open surgery. If it hasn't occurred, it's really angry and agitated, and they really don't think they're going to be able to treat it with antibiotics, then they're going to go ahead and do a laparoscopic procedure. If they have to have an open procedure, they're probably going to have an NG tube placed and be on IV antibiotics until that they can assess and make sure they do not have an infection inside the abdomen wall. Nursing interventions, we're going to take a history. We're going to assess the abdomen. We're immediately going to put them in NTO status because they possibly could be having surgery. We're going to do vital signs and pain management for these kids. Pre and post-op, because they're going to be in discomfort. Medical diverticulum. So a lot of you have heard of diverticulitis, right? So this is different than diverticulitis or diverticulosis. Diverticulosis is actually having those little pockets off the colon. Diverticulitis is when it's inflamed and infected and irritated. So medical diverticulum is the most common congenital malformation in the GI tract. So it's an omphalomesentéric fistula formation. So kind of like the same idea as that omphalocele. It's in that same area. So the small intestine connects to the umbilicus. Okay. So signs and symptoms you're going to see is inflammation, bleeding, and a bowel obstruction because stool's not able to pass because it's connected to that umbilical cord. How are we going to diagnose? We're going to do a CT scan, endoscopy, labs. Treatment, we're going to give IV fluids, antibiotics, and these kids are going to have surgery to resolve it because it's connected in the wrong spot and they're not able to pass stools, okay, and have absorption. So ulcerative colitis and Crohn's, this is those irritable bowel disorders, and again, I was talking to Essie about this before class, don't confuse these with IBS, irritable bowel syndrome, okay? Sometimes people who have ulcerative colitis and Crohn's will be misdiagnosed early on as IBS, okay? So with ulcerative colitis, you're going to have it's limited to colon and rectum, okay? So the small intestine is not involved. May result in ulcerations, adhesions, strictures, and fistulas. Signs and symptoms can be mild to severe. They're going to have bloody diarrhea or going to have a positive occult blood in their stool. They're going to have abdominal pain and growth abnormalities because they're not going to have good absorption of the nutrients they take in because of the constant diarrhea. Diagnosis, again, you're going to take a history. Labs are going to have an upper GI series, an EGD, and a colonoscopy. So treatment, we're going to reduce inflammation. So corticosteroids are the most common to treat. We're going to try to do high-calorie diets to be able to make sure whatever they do take in is they're going to have enough their body can absorb, high-calorie, high nutrition. And they may have to have surgery if any part of that bowel becomes too inflamed that gets necrotic. Okay, these people can end up with an ileostomy or colostomy. Crohn's disease, this involves any part of the GI tract. Okay, small intestine, colon, even up to that pyloric sphincter. Signs and symptoms are going to have abdominal pain, fever, diarrhea, nausea and vomiting, anorexia, weight loss, fatigue, anemia, delayed growth and development. They can have mouth ulcers or oral ulcers, intestinal blockages, periods of exacerbation and remission. So with Crohn's and even ulcerative colitis, you're going to have times they're going to have good times, they're not having symptoms, and then all of a sudden it's going to flare and they're going to have horrible symptoms, okay? So treatment is the same as ulcerative colitis, but these people are also treated, and ulcerative colitis sometimes too, are treated with those immunosuppression drugs like Humira, because it's kind of like lupus or another immune issue, because it's basically the body fighting against itself. Okay, so my brother-in-law takes Humana for his Crohn's. That's what he uses.
It's usually diagnosed in like the 20s or 20s.
Usually, yes. And it can, like my brother-in-law was 32 when he was diagnosed. Because he had some bowel issues growing up as a kid, but he didn't have severe. He did, like I said, they just thought it was kind of like IBS. And then whenever he actually had a stricture and that ileocecal valve that was inflamed, that's when he almost died and they said, oh my gosh, you have Crohn's. So, yeah, a lot of times you don't see a massive flare of this until like early 20s, mid-20s, but it can show up at any time.
When it says involves any part of the GI tract, what is it, just constriction?
It's inflammation that then leads to constriction or they can cause fistulas if you have breakdown of that wall due to the inflammation. So it usually is going to become like aggravated and inflamed, and then with that swelling, it's going to cause stricture. Okay, so you're not immediately going to have stricture, but over time, if that doesn't calm down, it's going to cause stricture. Peptic ulcers, these are usually caused by stress, medications like NSAIDs or H. pylori. Okay, how are we going to diagnose? Again, history, find out what kind of symptoms they're having, examination, labs, and upper GI. Treatment is usually medication, and if it gets severe enough, they may have to have surgery, okay, to close up, especially if it perforates through the stomach wall. Short bowel syndrome, this is a malabsorption disorder. It results from decreased mucosal surface area. So it can be due to necrotizing enterocolitis, gastroschisis, Crohn's, but also can be due to surgery. So if they go in and remove a big portion of that small intestine or large intestine, then that's going to cause short bowel syndrome. So it could be surgically related also. So you want to maintain optimal nutrition status, growth and development, and try to minimize complications. So treatment on these, they could be TPN or enteral feeding. So they may have an NG tube or a PEG tube or a little button if they're a little kiddo. They're going to have H2 blockers to reduce the acid, and you're also going to have the proton pump inhibitors and then the cholestyramine to be used for this. Forgot a colon there. GI bleeds, this also is covered in your adult lecture. So you can have upper or lower. So if you have an upper GI bleed, you're going to see coffee ground emesis, hematemesis, a bloody vomitus. Lower GI, you're going to have bright red rectal bleeding or tarry stools, which also is melena. Okay. How are we going to diagnose? Again, history, labs, endoscopy. Treatment is you're going to assess blood loss, establish hemodynamic stability, and give medication. Okay. So now what we're going to do is we're going to kind of do a focused pediatric abdominal or gastrointestinal assessment. So when we think of a focused assessment, we're focusing specifically on one system, right? So today it's gastrointestinal. So I want you to not just think about what you're going to focus on as far as the physical aspect of the assessment, but how are you going to approach it? What kind of questions are you going to ask? What kind of symptoms do you think might be there? So how do you approach asking those questions to a child? So let's say we have a 10-year-old who presents with diarrhea, nausea, and vomiting off and on for the last 2 years. Okay? So when we think about history, what are some things we need to ask and assess with their history? I already gave you some information. So how long, right? So we need to know how long the symptoms have been occurring.
Are we only asking the patient this, or are we also asking
Mom and dad and kiddo.
how many times they use the restroom?
Okay. Number of BMs. Okay. Diet.
Start with a certain type of food.
Okay.
What made you come in this time? What was the
What was the deciding factor? Okay. Okay.
medication, food wise?
History, medication, meds, allergies. Okay.
Have they been in before where they've had to have like disease
Okay.
procedures done?
Other procedures. Okay. What makes it feel better? Okay.
Do they have any previous hospitalization?
Okay. Previous admissions is what we'll say. Okay. So that pretty much covers a big majority of it, right? So we need to ask how long have they had the symptoms, number of bowel movements every day. Also with this, we need to know color, amount, consistency, blood. Okay, so you're going to have to get personal, okay, because we need to know, what does it look like? How often are you having it? Okay, and a 10-year-old little boy, are they going to be a little bit embarrassed? Do you think they may have told mom everything about what's going on? Probably not. Okay, so this is when you have to sometimes approach it as, okay, I know this can be scary. I know this is difficult. Maybe you're embarrassed. But we need to know everything that's going on so that way we can fix it. Because if you tell him you're going to try to fix it and make him better, he's probably going to be more apt to tell you, right? Because he wants to get rid of this, so whatever's causing his embarrassment, right? So you have to approach it in a certain way with kiddos versus adults, okay? So now that we got our information from our child, we're going to assess this, okay? So with a kiddo, where do we usually start assessing? Down, up, and the least affected area. We want to do the affected area last, because if it's painful, they're tender, as soon as you do that, do you think they're going to let you touch them anywhere else? No. You go to the immediate cause and issue. If it's painful, they're gonna be like, don't touch me again, okay? So you are gonna have to kind of, get your information. Say if you are in the ER and it seems like an emergent situation, you would start with the most painful or the problem, okay? Because once you figure out the problem, you can come back in and then assess the other systems, okay, in emergent situation, because that's what we're there to fix in the ER. But when you're in the office, not emergent technically, you want to start with the least affected areas to whatever the problem is. Okay, so we've assessed him, and now we're going to his belly, his GI system, so really mouth to anus, okay? So how are we going to inspect this kid?
Check skin color.
Okay. Skin color, size. What's the other one? Okay, temperature, is it warm? Okay, bulging, like in one specific place. Okay, so we're going to assess the mouth. Okay. Height and weight, okay, because that's going to be important if we have to medicate.
Is the stomach flat or is it?
Okay, so we've got bulging in one place, but is it flat or edematous? Is it shiny? Okay, if it's shiny, does that mean usually it's swollen? Yeah, usually when you have fluid in a certain part of the body, the skin becomes shiny because it stretches and becomes somewhat translucent, okay? You have shiny skin. Okay, what else? Okay, any scars? Okay, specific pain in one location maybe. Okay.
Any hemorrhoids from like straining chains?
Okay. Now, I would say we would probably do that one last, okay? Because that's really going to be embarrassing. So because you probably do want to see the anus, especially if he says, yeah, I have bleeding when I go to the bathroom, okay? It could be a fissure. Does anyone know what a fissure is? It's a tearing in that rectal tissue, okay? So sometimes if they're constipated and they're having large stools, that tissue is going to stretch and tear, and so they'll have bright red bleeding sometimes. It may not be specifically a hemorrhoid, it could be a fissure, okay? That can be common in kids with constipation, and you may not see it because most of the time it's up inside that rectal area, okay? So, anything else you can think of? Huh? You would do the full assessment. Yeah, you would want to do respiratory and eyes and all that. But right now we're focusing on that specific site. So this is pretty much, we're going to assess with our eyes because then we're going to palpate. Okay, so we're going to assess, we're going to look, see what it looks like. Is it swollen? And we probably are going to also, in this point, with kind of in between inspection and palpation, we could do the abdominal girth. Okay, because if he's coming in often, we want to see is that belly getting larger? Is it related to constipation? Is it related to ascites? Other issues. Okay, so palpation. So tell me what we're going to do for palpation. Okay. Okay. So we might do McBurney point. If it's a specific localized right side pain. Painful to the touch. What? Okay, right. Sometimes you're going to have to decide if you're going to do soft or firm palpation. Because can y'all remember something from a recent lecture that we would not want to palpate? Can rupture, but remember what it's called?
Wilms tumor.
Wilms tumor. They're Wilms tumor. If that kiddo presents with a bulging on one side that just recently occurred within the week, okay, because it grows quickly, you do not want to palpate that part of the abdomen part because you don't want to rupture it because it contains cancerous cells but it's usually contained. As long as it's removed intact, it doesn't spread. But if you open it, it's going to spread. Okay.
Is that the one also with the genetic, where it has like sacs inside the?
No, it's just an open. Yeah, it's just a tumor. Okay, so soft or hard palpation. Okay. What's something else? Something nurses don't really do often. Percussion. Okay. Think of like when you go into the supermarkets, your mom ever teach you how to slump a cantaloupe or a watermelon? Because that's going to tell you how dense it is inside, right? Do you want a good, flavorful cantaloupe or watermelon? But on quiche, you're going to usually tap. Okay. This is something we don't really do often unless you work in a GI clinic. If you work in a GI clinic and that's all you do every day, you're probably going to be proficient at percussion. Okay. But just a normal everyday nurse, we don't do it often enough, and so it's something the physician is probably going to assess. But percussion, correct. What is percussion going to tell us? Is there any fluid? Is there any air? Okay. Yes, because if it's full, it's going to sound dull. If it's open, then it's going to sound more of a hollow sound, right? Okay. So palpation, you're just going to feel, okay? You can do back because sometimes you want to feel, you're going to feel that spleen and liver to see if they're inflamed. You have to check pretty much everything that you can on these kiddos. So now we're going to go to auscultation. What are we listening for? Vowel sounds, okay. What else? How do we want them to be? We want them to be active.
Are hyperactive bowels generally bad?
Yes.
That can indicate like diarrhea or something.
Yes. Hyperactive is not good, just like slow. Yeah, hypo. So hyper or hypo, we don't want to see. Because if you have hypo, that means you don't have good peristalsis. Okay, so something's going on there.
Like an obstruction?
Yeah, like an obstruction, constipation, all those different things that's not going to allow that bowel to move. If it's hyperactive, then you're going to probably see lots of air, gas, diarrhea. They're also probably going to complain of abdominal pain with these, with a hyperactive.
What was the way to measure if it's hyperactive? Like, is it a certain sound?
Yes, you're going to hear it with the hyperactive. It's going to you're looking for frequency and character. Okay, so with hyperactive, normally you're going to just hear blah, 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 blah. Hyperactive is going to be constant. Okay, constant. And it's just like, when you hear your tummy growl, that's exactly what it sounds like through your stethoscope, is that little growly sound, okay? I don't know what the technical term for it is, but that's what I'm going to call it. So are we going to just assess one part of the abdomen? All four quadrants, okay? And we're going to document auscultated, all four quadrants, or quad time 4. And thankfully, with our new systems we have, you just have to click a button. Say all quadrants, upper, lower, because if you are, say you go in and you listen and the top vowels are pretty active, but the bottom vowels are hypoactive, because that can happen. You need to then, don't just click all within normal, because they're not. You then need to add your location and put what you heard, okay? Because that's not normal. And again, at some point in here, we're going to measure that abdominal girth, okay? So when we go to assess a kid, what is one thing we probably need to do, especially with an older child who's 10, when we go to touch them, what do we need to do first?
Ask for permission.
Ask permission, tell them what you're doing, okay? Because, again, we need to teach kids their body is their own. The only time they should be touched is when they give permission, okay? So, ask permission, kind of explain what you're going to do. Are you going to go up to him and say, okay, now I'm going to perform a physical assessment on you? Probably not a 10-year-old, because he might kind of understand those terms. He might not. You just kind of have to assess how he speaks to you. What words does he use? Because if you've got a really smart kid, he might know what a physical assessment is. If not, then you're probably going to go, okay, I need to come. I need to look at every part of your body, but I promise it won't take long, Or I need to look at your tummy first, or I need to, whatever the situation is. In ER, I need to look at your tummy first. Use terms they know, okay? And then sometimes if you have a smaller child, what can you do to make them feel more comfortable about what you're about to do? Have mom do it first. Maybe bring in a teddy bear and kind of show on the teddy bear what you're going to do, okay? That way it's not foreign. They've seen what you're going to do, okay? So when you're thinking about assessment of a child, you have to think about those things you have to kind of change specifically for a kiddo versus an adult, okay? Perfect, it's 9:31. So we will come back at 10. I'll give y'all a 30-minute break so y'all can have cookies and treats and all that. We'll come back at 10 and we're going to do Jeopardy, okay? And I'll leave this up here if anybody wants to take a picture or whatever.
Is there some lunch today?
No.